Hello, welcome to MRCS strategies, and today we'll be discussing the anatomy of the upper limb. So, the upper limb and lower limb anatomy are almost inevitable questions to meet in the exams. So, it's important that you acquaint yourselves with the anatomy of the upper limb and the lower limb. So we're going to start this discussion with the brachial plexus. And the brachial plexus is divided into the roots, the trunks, the divisions, and the cords. The roots, they exit from the intervertebral foramina, okay, and this is between the anterior and middle scaling muscles. Okay, so when they exit from here, they come together to form the trunk. At the level of the trunk, this is located at the base of the posterior triangle. And this is behind the third part of the subclavian artery. Okay. Now, the trunks, so the C5, C6 roots come together to form the upper trunk, all right? The C7 root continues as the middle trunk, and the C8 and T1 nerve roots join to form the lower trunk. Now, once this has happened, the trunk will divide, okay, into anterior and posterior divisions. And these anterior and posterior divisions will be located behind the middle third of the clavicle. All right? Such that the anterior trunk, the anterior division of the upper trunk joins the anterior division of the middle trunk, while the anterior division of the lower trunk continues, okay? And the posterior divisions, so all the posterior divisions come together, okay, to form the posterior cord. While the anterior divisions of the upper trunk and the middle trunk comes together to form the lateral cord. The anterior division of the lower trunk continues as the medial cord. The lateral cord gives off the lateral root of the lateral cord, and the medial root of the lateral cord come together to form the median nerve. And the cord is related to the second part of the axillary artery. Coming off the posterior cord are the upper subscapular nerve, the thoracodorsal nerve, and the lower subscapular nerve. The posterior cord also gives rise to the axillary artery and the radial nerve, while the medial cord gives rise to the ulnar nerve, the medial cutaneous nerve of the arm, and the medial cutaneous nerve of the forearm. So, the subclavian artery, so here we said that the subclavian artery was related to the trunk of the brachial plexus. The question is, how is the subclavian artery related to the trunk of the brachial plexus? So the subclavian artery is divided into three parts. Okay, the subclavian artery is divided into three parts by the scalene muscles. Okay, by the scalene muscles. Now, the first part of the subclavian artery starts from the origin of this vessel to the medial border of the anterior scalene muscle. Okay. Now, the second part, of course, will lie behind the anterior scalene muscle. And the third part will be from the lateral margin of the anterior scalene to the outer border of the first rib. And at the outer border of the first rib, it becomes the axillary artery. Remember that the first part of the subclavian artery gives rise to the vertebral artery, internal thoracic artery, and thyrocervical arteries. The second part gives rise to the costocervical artery, okay? And the third part gives rise to the dorsal scapular artery. All right, good. So next we'll talk about, next we're going to talk about the how does this affect the innervation of musculatures, okay? How does this affect the innervation of musculatures? So the long thoracic nerve, of course, innervates the serratus anterior, and it's important to know the nerve root. So the long thoracic nerve correlates to the C5, C6, C7 nerve roots. The dorsal scapular nerve innervates the rhomboids and the levator scapulae. The subscapular nerve, the suprascapular nerve, innervates the supraspinatus and the infraspinatus, and the upper scapular nerve innervates the subscapularis. The thoracodorsal nerve innervates the latissimus dorsi, and the lower subscapular nerve innervates the subscapularis and the teres major. The medial pectoral nerve innervates the pectoralis major and the pectoralis minor. Okay. So we have said all this, okay? Next, we move on to talk about some injuries that one may see in the brachial plexus, all right? Now, the branches of the brachial plexus, of course, is related to the third part. We remember that we said that the cord was related to the second part of the axillary artery. Therefore, it makes sense that the branches will be related to the third part of the axillary artery. Sometimes the brachial plexus can be compressed between the first rib and the clavicle. And this is typically seen in patients who have a cervical rib. And the symptoms could primarily be neurogenic, could be arterial, or could be venous. And this is called the thoracic outlet syndrome. With neurogenic symptoms, patient will complain of upper limb paresthesia, weakness. With arterial symptoms, patients will have symptoms of pain when they use the upper limb. And then with venous symptoms, you can see congestion in the region of the neck and the upper trunk. The injury to the long thoracic nerve of Bell, which typically will be seen in patients who are undergoing surgery for breast cancer, and if there's an injury to this nerve, the patient may come down with winging of the scapula. When patients do have mid-shaft humeral fracture, patient has wrist drop, but the extension at the elbow is spared, and this is because the triceps muscles are spared, and of course this is because the innervation to the tricep muscles has already been given off before the level of the fracture. When you consider injuries to nerve, you need to consider what is the motor affectation, and B, what will be the sensory affectation. Right. So concerning injuries of the brachial plexus, the two most common injuries that you keep hearing are injuries related to the injury of the upper trunk, which is the Erb's palsy, and injuries related to the injury of the lower trunk, which is the clump case paralysis. Remember that the upper trunk is C5, C6, and the lower trunk is C8, T1. Now, and then also remember that we also said that when a patient has an injury to any nerve, two things should be considered: the motor affectation and the sensory affectation. So if a patient has injury to C5, C6, we can almost imagine what will go on, because remember that the axillary nerve and the radial nerve, okay, are parts of the posterior cord. And this receives, and remember that the posterior cord receives innervation from C5, C6, C7, C8, T1. So it means that the nerve supply to the supply of the axillary nerve, the radial nerve, will be affected. And so what one will see is the supraspinatus. Okay, so there will be, so just to group them, so there will be paralysis of arm abduction. This occurs with the deltoid muscles, okay, and supraspinatus. Okay, so, and remember that the axillary artery supplies the deltoid. Sorry, the axillary nerve, pardon me, supplies the deltoid muscles. Okay, so, and the axillary nerve, the root value of the axillary nerve, interestingly, is C5, C6. Okay, the root value of the axillary nerve is C5, C6. All right, and the nerve, of course, supplies the deltoid muscle and the teres minor. Okay, so supplies the deltoid muscles and the teres minor. Now, what's the function? And remember that the teres minor is a rotator cuff muscle, all right? And then the deltoid is a shoulder, is an abductor of the shoulder. So, and then again, the axillary nerve also carries sensation, all right, to the shoulder, the skin that covers the inferior part of the deltoid muscle, okay, the inferior part of the deltoid muscle. So this tells you, all right, that there will be an increased risk of dislocation, because there will be weakness of the rotator cuff. All right. 2, is that the paralysis of the teres minor, okay, and the deltoid muscle will result in loss of arm abduction, okay, from 15 degrees. All right, so there will be loss of arm abduction. Okay, now, so if there's loss of arm abduction, okay, it means that, so let's do this. So if we say that there is loss of abduction, this means, or this is equivalent to, that the arm is adducted. Yes? Okay, let's go. There is also paralysis of the external rotators of the arm. Okay, so paralysis of the external rotators of the arm. So if there is loss of external rotation, okay, if there is loss of external rotation, then what will be the result? Internal rotation. And this external rotation is observed by the teres minor and the infraspinatus. Right? So it means that there will be weakness of the teres minor, which will increase the chances of shoulder dislocation. And there will also be weakness of the infraspinatus, which is responsible for external rotation. And we said that the infraspinatus and the supraspinatus are supplied by, we said that the supraspinatus and the infraspinatus are supplied by the suprascapular nerve. Okay. Yep. Fantastic. So this means, okay, this means that the nerve roots for the suprascapular nerve is C5 and C6. And remember, we are talking about the upper trunk palsy. Right? We are talking about the upper trunk palsy. Good. So yes. So now we have seen the loss of two functions, abduction and external rotation, meaning that the hand is adducted and internally rotated. So what next? All right. So the next thing is what other, so let's do this. So the branches, remember that C5, C6 is what? In terms of the branches, is musculocutaneous nerve. All right, is the musculocutaneous nerve. And the musculocutaneous nerve supplies the biceps, brachii, and the brachialis. And this causes flexion at the elbow joint. Right? Causes flexion at the elbow joint. So there is loss of elbow flexion. And what does this mean? Fantastic. It means that the elbow is extended. Right? It means that the elbow is extended. Okay. Now, we also said that one of the contributors to the posterior cord was C5, C6. All right. And the posterior cord also gave rise to the radial nerve. And the radial nerve supplies the brachial radialis. Right? Now, what is the function? Okay, what is the function of the brachial radialis? All right. Now, the brachial radialis helps to flex. So the brachial radialis flexes the arm, okay, pardon me, flexes the forearm at the elbow, okay, and also helps pronation, okay, and also helps pronation, sorry, pardon me, also helps supination, as it flexes the forearm, okay. So as it flexes the forearm, it also aids supination. And so if there is paralysis of the brachioradialis, okay, it means that the arm will be extended and pronated. All right. Then again, the radial nerve also supplies the extensor carpi radialis. Okay. So it supplies the extensor carpi radialis longus. All right. It supplies the extensor carpi radialis longus. And what does the extensor carpi radialis longus do? The extensor carpi radialis helps to extend the hand at the wrist joints. So the radial nerve also supplies the extensor carpi radialis. Okay, and this also helps to flex. Sorry, this helps to extend at wrist. Okay, this helps to extend at the wrist. So, as you can imagine, this will lead to wrist flexion. So, therefore, if you add all this constellation of symptoms, you have the typical policeman tip hand, or the waiter's tip hand, or the waiter's tip deformity of Ebb's palsy. Okay. So next, there is also loss of sensation to the radial side of the arm, all right, observed by the musculocutaneous nerve and the forearm. Okay, and don't forget that there's also loss of that patch of sensation at the inferior part of the deltoid muscle. Some of the causes of this injury is that for upper brachial plexus injuries, okay, it's usually seen with motorcycle riders who sustain an accident and they've been thrown off the bike, all right, and they fall in between their shoulders and their neck, okay, therefore stretching the brachial plexus, okay, at the level of the upper trunk. Again, it can also be seen in as birth injuries when there's shoulder dystocia. Okay. Next is the lower trunk injury, which is also called the clump case palsy. And the clump case palsy is injury to the lower trunk from which the ulnar nerve and from which the ulnar nerve originates from. Okay, and of course part of the median nerve. All right, so the major injury will be from the major symptom will be from injury to the ulnar nerve, which forms a large part of this nerve root. And so if you look at it, you find out that the motor affectation. So the next question you ask yourself is, so what are the functions of the ulnar nerve? Ulnar nerve injuries will lead to claw, hand deformities, right? And the reason for this is, number one, the ulnar nerve supplies the intrinsic muscles of the hand, okay? So intrinsic muscle hand is supplied by the ulnar nerve. Therefore, you find out that there is loss of, and the intrinsic muscles of the hand is responsible for fine movements, okay? Responsible for fine hand movements. Is responsible for fine hand movements. And when this is lost, when these intrinsic muscles of the hand is lost, then what happens is that it's evident that there will be wasting, all right, of these muscles and therefore loss of function. And so the intrinsic muscles of the hand in this situation will be mainly the hypothenar, the muscles of the hypothenar muscles, okay, which are supplied by the ulnar nerve, and the hypothenar muscles are the opponents, chiti, minimi, the abductor, chiti, minimi, and the flexor, digiti, minimi, brevis. Okay. The third and fourth lumbricals, the interossi, okay, the interossi, all right, muscles. Now, for the interossi muscles, we have the palmar, and the dorsal interossi. The palmar interossi adducts and the dorsal interossi abducts. Okay, and the dorsal interossi abducts the finger, okay, at the metacarpal phalangeal joints. All right, so the palmar interossi adducts the dorsal interossi, so the palmar interossi adducts the hand at the metacarpal phalangeal joints, at metacarpal phalangeal joints, okay, and the dorsal interossi abducts at the metacarpal phalangeal joints. Okay, good. What about the lumbricals? What does the lumbricals do? So the lumbricals help to flex. So flexion at the MC metacarpal phalangeal joints, okay, and extension at the interphalangeal joints, and extension at the interphalangeal joints. Okay. Now, so as you can imagine, if the ulnar nerve is doing this, okay, so this is the metacarpal phalangeal joint, and let's say these are the these are the interphalangeal joints. So it is flexing the metacarpal phalangeal joints, okay, and extending at the interphalangeal joints. So what does this mean? So if there is loss of extension here, so what happens is that if there is loss of flexion here, okay, if there's loss of flexion here at the metacarpal phalangeal joint, it means that to have a claw, you have extension now at the metacarpal phalangeal joints plus flexion at the interphalangeal joints. So this will give you the picture of a claw hand. So if you just do that on your hand, so extend your extend your metacarpophalangeal joint and flex your interphalangeal joint, and you see that you have clawing of the hand. Okay. Okay. So yeah, and the sensual affectation, therefore, will be loss of sensation at the ulnar border of the forearm and the hand. So there's loss of sensation. So there is loss of sensation at the ulnar border of the hand and forearm. All right. Okay. Next, we will turn our attention to the bones of the upper limb. All right. Now, it's important to be able to identify the bone of the, it's important to be able to identify the bones of the upper limb. Okay. And some of the points for identification is if you're given the humerus. All right. So if you're given the humerus and you're told to, so you might need an atlas for this part. So if you're given the humerus and you're told to articulate it, okay, how would you do it? So to properly, or they give you the bone of the humerus and say, is this the right humerus or is this the left humerus? To be able to do that, you must be able to articulate the bone in your mind. And some of the things that help you to articulate the bone, the humeral bone, is number one, you identify the greater tuberosity. Number two, you identify the lesser tuberosity. The greater tuberosity is facing outward, okay, and laterally. And then you identify the lesser tuberosity. In between the greater tuberosity and the lesser tuberosity, you have the bicipital groove, where the tendon for the long head of the biceps, all right, runs through it. The bicipital groove has a medial lip and has a lateral lip. And a common way we remember what is attached to the medial lip, lateral lip, or the floor of the bicipital groove or the intertubercular groove is the lady between two majors. So meaning that the latissimus dorsi attaches to the floor, all right? The pectoralis major attaches to the lateral lip of the intertubercular groove, and the teres major attaches to the medial lip of the intertubercular groove, all right? Next is posteriorly, you have the spiral groove, which houses the radial nerve and the profunda brachial artery. More inferiorly, you have two distinct structures. A, the capitulum, B, the trochlea. The capitulum articulates with the radial head, and the trochlea articulates with the trochlear notch of the ulnar. Once you have done this, you would successfully be able to say this is the right or this is the left humeral bone. The humerus can be fractured at the level of the supracondylar, at the level of the supracondylar line or supracondylar region. And this level is particularly important because of the rich neurovascular bundle that runs through this point. And these fractures are common in children. All right, these fractures are common in children, and they typically they can affect the brachial artery, they can affect the anterior interosseous nerve, okay, or the median nerve, they can affect the ulnar nerve, and they can affect the radial nerve. And so these fractures are usually treated with some urgency, and the treatment for this is open reduction and internal fixation. So going back to the bones of the upper limb, the coronoid fossa, okay, is in the anterior portion of the humeral bone, and it gives articulation to the coronoid process of the ulnar. The olecranon fossa is posterior, is in the posterior aspect of the humeral bone, and it gives articulation to the olecranon process of the ulnar. Okay, bone. Next, another key issue is, so the examiner says, can you articulate the humerus? Okay, can you articulate the humerus the ulnar and the radius for me? So it gives you the bone. It says articulate it, and is this the left or the right? And they might make it more difficult by throwing in the mix, you know, maybe the humerus from the left, the humerus from the right, the radius and ulnar from the left, and the radius from the right. And if you are not confident with articulating these bones, then you might be thrown off. But it's really easy. It's really, really easy. And one of the importance of knowing this is that it gives you some level of confidence when you take your exams. So now let's do this. So the key issue here, I mean, the only thing you need to know, and it's easy, is look for the radial tuberosity, okay, which is in the upper parts of the radial bone, all right, around the radial head, which is circular, all right. You look for the radial tuberosity and you direct it medially, because don't forget, that the biceps brachii is coming down, okay, medially, and attaches to it medially. So the radial tuberosity is directed medially. So once you direct the radial tuberosity medially, we've already identified the humerus, known how to identify the humerus and which part of the humerus it is. The next thing is you look for the coronoid process, look for the olecranon process of the ulnar bone. Olecranon process is posterior, coronoid process is anterior, and then there you have it. And then you have the radial fossa for the head of the radius, okay, on the ulnar, and then you articulate them. And there you have it, ladies and gentlemen, you've articulated the elbow joint. Next, we direct our attention to talk about the bones of the wrist. The bones of the wrist are interesting because it's really easy to remember them if you remember the mnemonic, right? That some lovers try positions, all right? Some lovers try positions that they obviously can't handle. Okay, some lovers try positions that they obviously can't handle. And this is scaphoid, lunate, triquetrum, okay, pisiform, trapezium, trapezoid, capitate, and hametes. All right, and this is listed from lateral to medial. Now, the key thing about this is that I'd like to talk about is the scaphoid bone. All right, because the blood supply of the scaphoid bone is peculiar in that when patients do have, in that the blood supply is retrograde. So the blood supply, instead of coming from the proximal aspect going to the distal aspect, comes from the distal aspect going to the proximal aspect. And so the blood supply to the scaphoid, so if this is proximal and this is distal, right, the blood supply comes like this. All right, so meaning that if there is a fracture here, the supply to the distal aspect is maintained, while the supply to the proximal aspect is lost. And this means that this bone is going to die off. And what we call death is necrosis. If it's of bone, is osteo. Therefore, you have osteonecrosis of the proximal fracture segment of the scaphoid bone. Okay. Now, we will talk about the different fossas. So, the different fossas, tunnels, canals, snuff boxes. So to start, we'll start with the cubital fossa. So the cubital fossa, superiorlaterally, is the medial edge. Okay, so superiorlaterally is the medial edge of the brachioradialis. Okay, so this is the brachioradialis. All right, so this is the brachioradialis. Medially, all right, is the lateral border of the pronator teres. Superiorly is an imaginary line through the medial and lateral epicondyle. Okay. And the floor is now composed of the brachialis, okay. So the floor made up of the brachialis and the roof is covered by fascia. Okay, and the content from medial to lateral, so the most medial is the medial nerve, then the brachial artery, and then the bicipital tendon. There is a carpal tunnel syndrome, all right? And the carpal tunnel is formed by the medial epicondyle, okay? So formed by the medial epicondyle. Okay, so it's formed by the medial epicondyle. The olecranon okay, so the medial epicondyle, the olecranon, and the ulnar head of the flexor carpi ulnaris. Okay, so and the ulnar head, so the medial epicondyle, the two heads of the flexor carpi ulnaris. All right, so the two heads pardon me, 1 minute. So, yeah, so the two heads of the flexor carpi ulnaris, okay, and then the olecranon process. All right, and then the olecranon process. Yeah. So, incidentally, something interesting here is that it is the second most common compression neuropathy. All right, the second most common compression neuropathy. All right, and this happens, all right, this happens between the two heads of the flexor carpi ulnaris, okay, or the arcade of Struthers, which is which is the medial head of the triceps, to the medial intermuscular septum. All right. So, and then of course, you will know that just to make this clearer for you, is that don't forget that the flexor carpionaris has the flexor carpionaris has two origins, okay? One from here and one from here, okay? So let me change this. Sorry. Okay. There. So one from the medial epicondyle, okay, of the humerus, all right? One from the medial epicondyle of the humerus, and the other from the medial aspects, and the other originates from here, something like this, okay? So you can imagine that if the borders are formed by, this, okay, and this, you can imagine that this forms a tunnel, all right? And as the nerve, as the ulnar nerve pass between the two heads, okay, as the ulnar nerve passes between the two heads of the flexor carpionaris, it can be entrapped, okay, right here, okay, can be entrapped, and this will cause ulnar entrapment syndrome, okay, and cause compression neuropathy. Okay, so next is the Goyon's canal. So the Goyon's canal, the roof of the Goyon's canal is formed by the volar carpal ligament. The floor is formed by the transverse carpal ligament, and the ulnar boundary is formed by the pisiform pisohamate ligament, abductor digiti minimi, and radially the hook of hamate. And the ulnar nerve again can be entrapped here. All right. So we've seen ulnar nerve injury when we spoke about we talked about the club case, palsy. Now B, we've talked about the cubital, tunnel, entrapment. Now C, we are talking about the Goyon's entrapment in the Goyon's canal. And this is all on a nerve. Okay. Good. So next, the everybody's favorite, the carpal tunnel. So the carpal tunnel is the surface marking for the proximal edge of the flexor retinaculum, all right, which will form the roof of the tunnel, is the distal skin crease, all right, of the forearm. And the boundaries of the carpal tunnel, the floor is formed by the carpal bones, of course, and the roof is formed by the flexor retinaculum. The proximal attachment of the roof is to the pisiform and the tubercle of the scaphoid, and the distal attachment is to the trapezium and the hamate. it has certain structures, all right, 4, 8, 9, 10, 11. Okay, so 11 structures. So this is a really, really tight, it can potentially be a really tight compartment. And the tendons that go through this compartment, the structures through this compartment, are the tendons of the flexor digitorum profundus, flexor digitorum superficialis, flexor pollicis longus, flexor carpi radialis, and the median nerve. The median nerve can be entrapped, okay? So median nerve entrapment. All right, the median nerve can be entrapped in this canal, okay? And this is what is called the carpal tunnel syndrome, all right? And a useful, so if they say how would you test for entrapment of the median nerve in the carpal tunnel syndrome, then your answer will be to do the Tinel sign, the Phalen's test, or the reverse Phalen's test. All these are all provocative testing. So this will bring up the symptoms of carpal tunnel, of the carpal tunnel. Okay, good. So remember again that there is also what is called the pronator syndrome, or the pronator teres syndrome, which is also compression of the median nerve at the forearm. All right. Okay. So if you can just do, so we'll talk about the anatomic snuff box now. If you can just do something for me, so raise your forearm up with your palm. Okay, I prefer you do this with your right. All right, with your palm, okay, in almost mid supination. Okay, so let your palm or your hand be in mid supination. In that position, you can see the anatomic snuff box. And the boundary, okay, so you should be seeing something. If you've done that, you should be seeing something like this. Okay, should be seeing something like this, where this is pointing towards the thumb. This is the wrist. Okay, this part should be facing you. Okay, so your hand should be mid supination. All right, so and then this faces you, and this is away from you. Okay, fantastic. So if you've done that and you've put your hand, all right, so if you've done that and you have extended your hand, all right, extended your thumb, you'll find out that this part, okay, this part, so let's discuss the boundaries now. So the anterolateral boundary, all right, the anterolateral boundary, which should be facing you, okay, so the anterolateral boundary, which should be facing you, is formed by the abductor pollicis longus and the extensor pollicis brevis. So the abductor pollicis longus, all right, and the extensor pollicis brevis. While posterior-medially, you have the longer one. Let's do this. While posterior-medially, you have the longer one, the longer tendon, which is the tendon of the extensor pollicis longus. All right, and the extensor pollicis longus will insert into the base of the distal phalanx. That's why it's longus. And the extensor pollicis brevis will insert into the base of the proximal phalanx, hence brevis. All right, good. So let's now turn our attention to the nerves and the important things we need to know about the nerves. So for the nerves, we have the okay. So we did say that the key issue here is for each nerve, you need to consider two things. Number one was what? The motor distribution. And number two was the sensory innervation. Okay. All right. The motor distribution for the median nerve is to the flexor and the pronator muscles, okay, of the anterior compartment, essentially. And this includes the flexor and pronator muscles, except for the flexor carpi ulnaris, okay, and the ulnar aspect of the flexor digitorum profundus. Now, remembering this is important because it is going to determine in the long run your understanding of the median nerve and ulnar nerve injuries. Okay, so supplies everything but the flexor carpi ulnaris and the ulnar aspect of the flexor digitorum profundus. The hand, okay, the hand, in the hand, it gives the recurrent branch. Please remember this, okay? Please remember this. So it gives the recurrent branch to the thinner muscles, and it gives a palmar branch to the first and second lumbrical muscles, okay? To the first and second lumbrical muscles. So, question. If there is an injury, so when we consider injuries to the median nerve, okay? When we consider injuries to the median nerve, I said we consider motor distribution, and the motor distribution of the median nerve, we will consider the forearm and the hand. When we consider the hand, we'll consider the loaf, all right? And the loaf was the first two lumbricals, okay? The opponents, pollicis, all right? The opponents, pollicis, then we have the abductor, pollicis brevis, and then we have the flexor, pollicis brevis, okay? So lumbricals, opponents, pollicis, abductor, pollicis brevis, and flexor, pollicis brevis. All right. Now, the sensory distribution, okay? The sensory distribution is to, so if we did this, sorry, the sensory distribution all right. Now, so the sensory distribution in the palm is the lateral. So this is lateral, this is medial. And as you can imagine, this is the left hand. So the lateral two-thirds of the palm, okay, all right. So the lateral two-thirds of the palm, yeah. Then the lateral 3.5, 1, 2. So 1, 2, 3.5. Okay. All right. And if this is the palmar surface, let's do the 1, 2, 3, 4. Okay. And this is the dorsal surface. All right. And we are saying that this includes the tip of the extensor surface. All right. of the hand. All right. So this is the distribution of the median nerve. All right. The sensory distribution of the median nerve. And so let's talk about injuries to the median nerve. All right. Injuries to the median nerve. So at the level of the elbow, if there is an injury there, it's going to cause weakness of the flexors. All right, of course, except the medial half of the flexor digitorum profundus, which is supplied by the ulnar nerve. All right, and when this happens, the patient cannot make a fist. And so if you imagine that the flexors, all right, helps to flex the fingers, okay, and make a fist. All right, helps to flex the finger and make a fist. And you can notice that as you're doing that, so if you take your hand, flex your finger, as you're doing that, you can notice that you are also opposing your thumb. All right. And remember that the median nerve supplies muscles that cause thumb opposition. So the loss of this, okay, will mean that the patient can't do the OK sign. All right. So can't do the OK sign. So cannot make a fist. All right. Can't do the OK sign. Because remember that the medial flexor digitorum profundus, all right, is still intact. All right. So the patient will be able to close that. But the opposition of the thumb and the flexion of the second and third fingers is lost. All right. So as you can imagine, these injuries are common in supracondylar fractures. All right, are common in supracondylar fractures. And what will happen? We say so. Let's list the muscles that will be affected. So there will be loss of pronation. All right. And if there's loss of pronation, it means that the hand will be supinated. Okay. There will be loss of flexion. At the radial half of digits. Okay. And thumb. And I said this was first, second, third finger. 3 is what? There is loss of abduction. Loss of abduction and opposition of thumb. Okay. Now, if you consider all of this, the loss of pronation, okay, meaning that the hand will be supinated, loss of flexion, all right? So if you ask the patient to do an okay sign, he can't do it because that will require the flexion, okay, of the first three fingers. Because of the median nerve also supplies the abductor pollicis brevis, the flexor pollicis brevis, okay? Remember we said it was the loaf, lumbricals, flexor pollicis brevis extends, flexor pollicis brevis, abductor pollicis brevis. So you find out that there's also loss, and because of the loss of that flexor pollicis brevis, okay, there's loss of flexion at the thumb, which is the first finger. The loss of flexion in the second and the third is because of the loss of function of the flexor digitorum profundus and superficialis. And so I can do this for you and say this is loss of flexion at thumb. That is flexor pollicis brevis, all right, plus loss of flexor pollicis, flexor digitorum superficialis plus lateral half of flexor digitorum profundus. Okay, so and then there's loss of abduction and opposition of the thumb, which is opponens pollicis, weak, okay, abductor pollicis brevis, weak. Okay, so you can see what's going on, and so that's what happens. Okay, so if we combine all of this, can you, with your arm, now see what's going to happen? So there's loss of pronation. So can you put your hand in supination? Yes. There's loss of flexion. Okay, so your hand is extended. All right. So the hand is extended, and the hand that will be extended will be the second and the third finger. All right, while the others can flex. Okay, while the others can flex. Okay, so I'm going to show you two things. So while the others can flex. So if you have done that correctly, you should almost look as if you're doing a gun sign with your hand. So something like this. Okay. Okay. All right. So if you attempt to flex the fingers, this is what will happen. All right. This is what will happen. And so this is what is called benediction. Sign. All right. Benediction sign. Good. Now, the fact, so the benediction sign is sort of an active movement, okay? So attempt at flexion. And passively, what happens is that passively, So passively, without attempting to flex, there is the ape hand deformity. So I can tell you that the A and B of median nerve injury at the elbow. All right. So the A and B of the median nerve injury at the elbow. So the A is the ape hand or the ape deformity, and the B is the benediction sign. Median nerve injury at the elbow. Of course, would you expect? So what would you expect to see in terms of what would you expect to see? Remember, we said that there's the motor part, and then there is the can't bless you injury at the elbow joint. The OKA and B is the injury for the whole median nerve, mnemonic for the whole median nerve. But at the elbow, it's not okay if the priest can bless you. All right. So the ape hand deformity it's really easy, because when you talk about the ape hand deformity, it is deformity of the muscles supplying the hand, because that's injury at the wrist. And so injury at the wrist will affect the muscles supplying the hand. And this means that the loaf, okay, muscles are affected. And if the loaf muscles are affected, all right, it means that no opposition, all right? So there'll be loss of opposition. So the thumb will be adducted because there is loss of opposition and loss of abductor pollicis longus. So the thumb will be abducted. There will be loss of will be adducted. There will be loss of opposition, and there will be loss of flexion. Okay, so this goes, all right. And when that happens, okay, the patient has an ape-like hand, all right, something like this. So the hand is, so the hand will be ape-like, okay. Okay, the hand will be ape-like, all right. So no flexion, no opposition at the thumb. This is really important at the thumb, and no abduction. Okay, so ape hand. All right. Of course, we also consider the sensory deficit, and the sensory deficit is that we say that there will be loss of sensation to the lateral 2/3 of the palm and the lateral 3.5 fingers. Okay, so the sensory supply of the median nerve will be lost. Okay, all right, good stuff. Now, the ulnar nerve is now, before I proceed, I would like to teach you something, and what I would like to teach will be related to the type of motions that you can have at the fingers, at the level of the fingers. Because sometimes, if you realize, sometimes when I say flexion, abduction, what's the difference between flexion and abduction in the finger? What's the difference really? What's the difference between flexion and opposition in the fingers? It's important for you to know, okay? Now, finger, this is finger. So if this is the palm, so this is finger. So this is finger abduction. Okay, that's finger abduction. And this is finger adduction. Okay, this is the thumb. Okay, this is the thumb, and it's adducted. Okay, when you face it forward, directly forward, okay, this is when you face your thumb directly forward, all right, it is finger abduction, all right, directly forward. When so when the thumb is pointing out, all right, is at right angles. So when the thumb is at right angles to the palm, you have abducted it. Okay, and when it is at the level of the palm, okay, say 180 degrees, okay, you have adducted it. All right, good. So what about extension? Okay, so extension, so the surface, let's say the surface of palm, because I did that because extension is also at 90 degrees, but this is it. So extension is like this. Okay, and this means that extension, this is at right angles. So right angles to the lateral border of the index finger. Okay, so if you put the thumb at right angles to the lateral border of the index finger, you have extended it. While if you put the thumb, okay, to right angles to the surface of the palm and the fingers, then you have abducted it. You have abducted it. All right. And opposition is when I use the thumb to touch another finger. All right. So this is really going to be something to draw. Okay. So 3, then okay. So All right, good. So this is opposition. All right, so the thumb is opposing with the fingers. All right, so this is opposition. Flexion, all right, flexion is somewhat like opposition, but this time there is no movement at this little finger. So flexion is somewhat like opposition. So in flexion, we have that. Okay, so this is flexion. Okay, so we said that there is abduction, all right, in which the thumb is at right angles to the surface of the palm, and this is opposed to extension, in which the thumb is at right angles to the lateral border of the index finger. We said that adduction is when the thumb is parallel to the index finger, okay, or the lateral border, index finger and the lateral border of the palm. And we said that flexion, all right, is opposition, but this time you're not bringing any other finger to meet the thumb, okay? Everything is all straight out, all right, like that, okay? And this is flexed. While opposition, the thumb is flexed and another finger is flexed, okay? So just for your knowledge. And so so the ulnar nerve, fantastic. So the ulnar nerve, we talk about that, we say that the root of the ulnar nerve is C8 and T1. And like we always said, we always consider the motor supply and we always consider the sensory supply. And we said that the ulnar nerve supply the flexor carpi ulnaris and the medial half of the flexor digitorum profundus. Good, good, good. Now, we also went on to say that the muscles, the function of these muscles, okay, so so they are injury, so we'll consider two things: injury of the ulnar nerve, all right, injury of the ulnar nerve at the elbow, injury at the wrist, okay, injury of the ulnar nerve at the elbow and injury of the ulnar nerve at the wrist. Okay, now, so what happens with these injuries? Again, I'm going to go through the function with you. So the ulnar nerve, the deep branch of the ulnar nerve, supplies the intrinsic muscles of the hand, okay, which we have outlined before. Which was, just to mention this again, which was the interossei and the hypothenar muscles. And we said that the hypothenar muscles was the opponens digiti minimi, the abductor digiti minimi, and the flexor digiti minimi brevis, the lumbricals and the interossei, the third and fourth lumbricals and the interossei. So, in other words, the digiti minimis, okay, which will be abduction, digiti minimi, opposition, digiti minimi, so opponens digiti minimi, and flexor digiti minimi. So think of it as it's almost the same muscle we saw in the thumb, in the thenar muscle, the loaf muscle, the abductor pollicis brevis, the flexor pollicis brevis, and the opponens pollicis. This time we're talking about the abductor digiti minimi, flexor digiti minimi, opponens digiti minimi. And then we talk about the lumbricals. And it is the what? Lumbricals, the third and the fourth lumbricals. And we said the interossei. And then we had the dorsal interossei and the palmar interossei. And the dorsal interossei, we said abducts, and the palmar interossei adducts. Good. So now we're ready to talk about the what will happen if there was injury at the elbow. So injury at the elbow we include, so what do we take off now? Let's take this off now. Okay, sorry, I need the space. Okay, so yeah, nice, good. So when we say injury at the elbow, this can be from, say, supracondylar fractures, or from cubital tunnel syndrome. Okay. Remember, as the ulnar nerve passes between the two heads of the flexor carpi ulnaris, we said that. So what happens at the elbow? Let's go. So at the level of the elbow, all right, the patient will experience, so when there's injury there, the patient is going to experience weakness in flexion of the hands, okay, at the wrist. So and this is first of all, the loss of the flexor, so flexor digitorum profundus, so the medial half, and flexor carpi ulnaris. Okay, this is lost. All right, and when this is lost, it means that there is loss of finger flexion. All right, loss of finger flexion. And if there's loss of finger flexion, what do you think? And mind you, this finger flexion is in the fourth and fifth digits. And so if there's loss of finger flexion, I mean, it means that the extensor will be unopposed. All right. So loss of finger flexion means extensor will be unopposed, means extension at fingers. And this extension at fingers is largely extension at the fourth and fifth metacarpophalangeal joint. Remember that the intrinsic muscles of the hand, okay, the intrinsic muscles of the hand causes this. We said it before. Okay, flexion at the metacarpophalangeal joints and extension at the interphalangeal joint. All right, good. Okay, so there will be extension at the fourth and fifth metacarpophalangeal joints. All right, and there will be flexion. Okay, there will be flexion at the interphalangeal joints. Okay, at the interphalangeal joint. So there will be flexion at the interphalangeal joints. Okay, good. So there is also an additional symptom you're going to see, because remember, in all of these, we talked about the abductor. For the median nerve, we talked about the abductor pollicis brevis, opponens pollicis, the flexor pollicis brevis, the first two lumbricals. But there is also an adductor pollicis. And the adductor pollicis is responsible for adduction of the thumb. And this is supplied by the ulnar nerve. Okay? Yeah? All right. So this is supplied by the ulnar nerve, the deep branch of the ulnar nerve. Now, it means that if you tell the patient, so there'll be weakness of adduction of thumb. Okay, and we said that adduction of thumb was when the thumb was parallel to the lateral border of the palm and the index finger. And so if there's weakness of adduction, if you ask the patient if you try to perform the Froment's test, which you put a paper in between the thumb and the index finger, that lateral border, and you tell the patient to hold it, and then you do the same on your hand, hold the paper together. So if it's like this, so if this is the patient's hand, okay, let's do this. So if this is the patient's hand, all right, and this is the examiner's hand, all right, we put a paper, sorry, let me do this. So we put a paper here, okay, in between the two hands, and we say, hold it like that. Hold the paper in adduction, okay, while adducting the thumb. And then the examiner tries to pull the paper, okay, from the patient. What will happen is that instead of the patient to use adduction to hold paper, he will flex the thumb. And remember, we said thumb flexion was like flexing the thumb on the surface of the palm, okay? So crossing the thumb over the palm, but this time none of the fingers, all the fingers are straightened out. So he will try to, he will compensate for the weakness of adduction by flexing his thumb. And what causes thumb flexion? Medial nerve. And in this case, medial nerve is not injured. And so you will see thumb flexion, and you will see that it is weak, and you can easily pull this paper from the patient's hand. And this is called the Froment test. Okay, ladies and gentlemen. Yep. All right. Or the Froment, yeah, well, the Froment sign rather than the test, pardon me. So the Froment sign. Okay, it's called the Froment sign. All right. Good. Yeah, so I diverted a bit to tell you about that. So we'll go back to the injuries, yeah? Okay. So what has happened in essence is that you see here that there is extension, okay, of the fourth and fifth digit at the metacarpophalangeal joints. Okay, at the metacarpophalangeal joint, and there is flexion at the interphalangeal joint. Now, question. We'll get there. We'll get there. So let's talk about, so I'm going to come back to injuries at the level of the elbow, and then compare that to injuries at the level of the wrist. So at the level of the wrist, all right, injuries at the level of the wrist produce what? Clawing, same thing, clawing. So injury at the elbow versus injuries at the elbow, right? So injuries at the elbow versus injury at wrist. Okay, now I'm going to say that, let's see, fantastic. So now, so we have said that whether the patient has injury at elbow or injury at wrist, both equal clawing. Okay, key issue. Okay, key thing to remember. Both involve clawing. There's loss of sensation, paresthesia to the medial aspect, medial 1/3 of the palmar surface of the hand, and the medial aspect of the palmar aspect of the finger of the fifth digit, and half of the fourth digit. Okay, now, good. So the issue is to differentiate the injury at the wrist with the injury. So both of them cause clawing. So how do you differentiate whether the injury is at the wrist or the injury is at the elbow? So the question is, which clawing is worse? So injury at the wrist, okay, produces So injury at the wrist produces worse clawing. All right, produces worse clawing, and that's because the flexor digitorum profundus, all right, and flexor carpi ulnaris with injuries at the wrist, okay, are active. Okay, so with injury at the wrist, flexor digitorum profundus and flexor carpi ulnaris are active. And since they are active, they will cause finger flexion in addition to the extension at the metacarpophalangeal joint. Okay, and when this happens, you find out that the clawing is worse just because finger flexion is active. Okay, finger flexion at the fourth and fifth is active, and so this is called the ulnar paradox. Paradox because it's a weird thing. It's an unusual thing because typically one should expect that the clawing should be worse with higher level injuries, these at the elbow. Okay, but with higher level injuries, the flexors are paralyzed. The flexor digitorum profundus and the flexor carpi ulnaris are paralyzed. And if they are paralyzed, they cannot cause profound clawing. Okay? And so that's why it's a paradox, because typically we know that the higher the injury, the worse the neurological symptom. All right? And so that's why it's called an ulnar paradox. Okay? All right. The next thing is that it's important to know how to test the flexor digitorum profundus and the flexor digitorum superficialis. And to test the flexor digitorum profundus, you need to remove the action of the flexor digitorum superficialis. Now, the flexor digitorum profundus attaches to the base of the terminal phalanx, and the flexor digitorum superficialis attaches to the base of the proximal phalanx. So when you are testing them, you need to, so if you're testing the flexor digitorum profundus, you need to obliterate movement at the interphalangeal joints. Okay, and if you stop the movement at the interphalangeal joint, which you're seeing here, all right, all that is left is that, so you have removed the movement of the flexor digitorum superficialis, and all that is left is the tendon of the flexor digitorum profundus, all right, and that is causing flexion at the distal interphalangeal joint. The same thing, if you want to test the flexor digitorum profundus, then you need to eliminate the movement of the, if you want to test the flexor digitorum superficialis, you need to eliminate the movement of the flexor digitorum profundus. And to do that, you need to stop the distal interphalangeal joint from moving. And so all that moves is the proximal interphalangeal joint, as you can see here. Now, the rotator cuff, of course, is deficient in the inferior aspect. And this is one of the reasons why there's instability of the shoulder joints. Okay, this is one of the reasons there's shoulder joint instability. Now, the rotator cuff comprises of the supraspinatus, infraspinatus, and we said these two were supplied by, sorry, I need to change that. These two were supplied by the suprascapular nerve, the teres minor, all right, the subscapularis, which is supplied by the upper and lower subscapular nerve, and the teres minor supplied by the axillary nerve. Okay, good. And we said that injury to any of the nerves supplying the rotator cuff will make it weak and put the shoulder joint at risk of dislocation. Okay, having said that, we will then talk about the quadrangular space, all right? And the quadrangular space is bounded superiorly by the teres minor, inferiorly by the teres major, medially by the long head of the triceps, and laterally by the surgical neck of the humerus. And it contains the posterior circumflex humeral vessels and the axillary vessels. And inferior dislocation of the shoulder can injure these vessels and cause symptoms, neurovascular symptoms. The axillary nerve, we said, supplied the deltoid and the teres minor, and sensation to the lower half of the deltoid, which is the regimental barge area. And the problem there with injury to the deltoid and teres minor is that there's inability to initiate, to continue shoulder abduction up over 15 degrees, okay? And there's loss of sensation to the barge area. And remember that the initial abduction from 0 to 15 degrees by the supraspinatus, okay? And then it's also important for you to know the different parts of the axillary artery, and the axillary artery is divided into 3 parts by the by the pectoralis minor. And the pectoralis minor has the medial, and the pectoralis minor divides it into 3 parts. The first part is medial to the pectoralis minor, and that gives off the superior thoracic artery. The second part, which is behind the pectoralis minor, gives rise to thoracoacromial artery and lateral thoracic artery. And the third part, which is lateral to the pectoralis minor, gives rise to the subscapular artery, the anterior circumflex artery, and the posterior circumflex humeral artery. And we also went ahead to, and then again, we said that the musculocutaneous nerve supplied the biceps muscle and the brachioradialis, and that the biceps muscle, the long head of the biceps muscle inserts into the supraglenoid tubercle, and the short head of the biceps muscle inserts into the coracoid process, and you have the bicipital tendon and the long head of the biceps tendon running in the bicipital groove, and the tendon inserts into the radial tuberosity, which you will orient medially to be able to orient the bones. The radial nerve, of course, supplies the triceps muscle, and the triceps muscle has 3 heads: the long head of the triceps muscle, the medial head of the triceps muscle, and the lateral head of the triceps muscle. And the long head of the triceps muscle is coming from the infraglenoid tubercle, and the lateral head comes off above the spiral groove, and the medial head comes from below the spiral groove. And within the spiral groove, we said we had the radial nerve and the profunda brachial artery. It's also important for you to know a bit about the scapula, And so in the scapula, we have the anterior surface of the scapula, the posterior surface of the scapula that is divided into two by the spine of the scapula, into the supraspinous fossa and the infraspinous fossa, from where you have the supraspinatus and infraspinatus that is innervated by the suprascapular nerve, and then the subscapularis in the front, in the subscapular fossa, which is innervated by the upper and lower subscapular nerve. And then the scapula had the coracoid process, and the coracoid process, to identify the coracoid process, the coracoid process is just below the junction between the lateral 1/4 of the clavicle and the medial 1/3 of the clavicle. So if you go just below there, roughly about 1 cm below that point, then you have the surface marking of the coracoid process. And the coracoid process is important because so many ligaments that are responsible for the stability of some of the joints and the articulation around that region are attached to the coracoid process, such as the coracoclavicular ligament, the coracohumeral ligament, the coracoacromial ligament, and the coracoid process also gives origin to the coracobrachialis, the short head of the biceps, and the pectoralis minor. Again, it's important for you to also remember that it's vital, okay, that is vital for you to practice, okay, practice, and that's the key. Practice. So at the end of this video, I've included a specimen of anatomy mocks, okay, that you can use to try and remember what we have spoken about in this lecture series. Thank you very much. This is MRCS Strategy. We will see you some other time. Okay? So thank you very much, and bye for now.